Welcome to the Neural Implant Podcast, where we talk with the people behind the current events and breakthroughs in brain implants in an understandable way, helping bring together various fields involved in neuroprosthetics. Here is your host, Ladan.
Hey everyone, and welcome to the Neural Implant Podcast. Today's guest is Richard Hanbury, and he is the founder and CEO of Sana Health. And actually, this is really interesting. This is a sleep mask, which has a mask and earbuds. And you wear this over your eyes, and it helps you sleep. So it kind of pulses using algorithms, light and sound to put you to sleep and to kind of sync up both hemispheres of the brain. Pretty successful. You know, he's been raising a lot of money with this smart sleep mask, so you don't have to have sleep drugs or anything like this. Really interesting. Richard Hanbury, pleasure to have you on the show. You are the founder of Sana Health, which basically is a sleep mask with kind of neural stimulators that go into your ears, and it flashes lights too, right?
It uses pulsed light and sound.
Pulsed light and sound, and then you do heart rate variability measurements, and this reduces anxiety and helps you sleep. And so all those people paying lots of money for expensive mattresses, that was a bad idea. You should have just gotten this, right?
We are on market as a wellness device for improvement. And within the problems that people have with sleep, obviously the mattress business and getting people comfortable is the large chunk that I think is totally unnecessary. And I would be very glad to see it disappear is the drug side of it. Ambien has such a poor track record of safety and efficacy that it only exists because something better doesn't exist. Within the sleep side, we definitely would like to be an alternative to that. And on the rest of the side, I started this whole thing because of solving my own chronic pain problem. But yeah, we've got 10 clinical trials that will be completed in the next 24 months. One that has already started on neuropathic pain in Mount Sinai. Another big one that's due to start in Duke in a couple of weeks' time on fibromyalgia. We're starting as a wellness device, but we are very much on the track of clinically proving out how we can help people in lots of different circumstances of pain, anxiety, depression, and getting those proved through the FDA so that we can then go to market.
Yeah, that's really cool stuff. So how does this work? What's kind of the science behind this?
So I originally had my accident, as you pointed to before. I had to drive a Jeep off a bridge to avoid a head-on collision with a petrol truck. And that left me with spinal injuries and a nerve damage pain problem that was so severe I was given a 5-year life expectancy. In hospital, standard of care for neuropathic pain really hasn't changed much in 28 years. There are the Medtronics and Abbotts of the world who will claim that their spinal cord stimulators are significantly better. The evidence shows that they are somewhat better, and there are a very important class of people that they work for, but there are a very large number of people that those kind of spinal cord implants just don't really manage to help, and unfortunately I was one of those. So you go through a process of opioids, gabapentin, other drugs, then they look at TENS machines, implantables, and once they've ruled all of that out, then to offer you what used to be called meditation and now would be called MBSR, mindfulness-based stress relief. And when your pain levels are sort of 20 out of 10 and your meditation ability is 0, trying to learn how to meditate is a total waste of time. You have an electrical storm going on in your head. Trying to put your attention on something else just isn't a viable option. It's a viable option if your pain is at a low level or episodic. You can learn to meditate in the areas where the pain is less and then try and use that when the pain is more. But once you're over a certain level, it really doesn't work very well. And so I gave up on the idea until I watched a particular movie that was alternately good and bad the whole way through the film. That changed my pain levels more than morphine. And at the end of the film, I realized that my pain levels had changed more than morphine. And the second thought was, the bits of the film that made me feel less pain made me feel like I used to when I was skiing. So I was like thinking, okay, so if I could reliably change states of consciousness as you are trying to do a meditation, that would actually be a way of solving my pain. So I then looked at all of the underlying research into the effect of meditation on EEG patterns in long-term meditators. So not just how does your brain change while you're meditating, but how does meditating change your brain over time? And the reason why I went that route was because I thought, well, if I'd already meditated for 20 years before I had this accident, that would be really useful right now. So the next thought was, okay, well, what do the brains of 20-year-long meditators look like? And how do I get to that state? And luckily for me, there was a brilliant neuroscientist called Maxwell Cade, who in the 70s, 2 channels, so very simple EEGs on a very large number of long-term meditators, 5, 10, 20-year meditators. And he showed how the more you meditate, the more certain things happen in your brain. So 2 things in particular. One, you get a frequency distribution pattern where you get less high frequency activity, less beta wave activity, more alpha wave activity, more theta, and a reasonable amount of delta. So that's a really important thing. And to change states of consciousness into those 3 states, you can do that with other sites of stimulation. You can do that with magnetics, neural implants. For example, the Medtronic one on deep brain stimulation for Parkinson's uses essentially an alpha frequency from within inside the brain. But there was a second factor on what was common to all these long-term meditators, and that was perfect hemispheric balance between the left and right hemispheres on this 2-channel EEG system. Now, there's a lot of argument and dispute as to how valid those 2-channel systems are. I didn't know that at the time, and I didn't care. I was just like, okay, well, if I measure my own brain on that system, what does it look like? And my brain showed a very large disparity between left and right hemispheres compared to the perfect balance of every long-term meditator. So, okay, I need to try and change that. And if you use audio-visual stimulation, you can stimulate the left and right hemispheres of the brain independently and together in a way that allows you to recreate that hemispheric balance. And that is the key to allowing the brain to then get itself into a more deeply relaxed state, which then increases the degree to which the brain will go through neuroplasticity to get back to homeostasis. So the original device I made, EEG, where it was a manual creative feedback loop where I was changing the stimulus to get the response I needed from my brain. Over the course of 3 months, that took me from 24 hours a day of being in pain. I was lucidly dreaming most nights of how much pain I was in, and went from that to my first 24 hours without any neuropathic pain in 3 months. And then I haven't had a minute's nerve damage pain since then. And it took about 6 months after that before I realized that the pain was never actually coming back. And on the day I sort of finally realized and accepted that, so how can I use this to help other people? That changed the journey from being a personal journey into, okay, so how can I use this to help other people?
That's really cool. So you kind of hacked your way into getting better. You kind of threw this thing together and, used the latest neuroscience and kind of looked at the results of the best meditators in order to see what they need to do or what they have that you don't. That's amazing. Why was yours so misaligned?
Well, it turns out that it is a signature pattern of almost everyone with long-term chronic pain is to have this hemispheric imbalance, and usually a large one. It's also a signature that you find in very large amounts of anxiety and chronic anxiety and things like PTSD. It's one of the reasons why, for example, if you ask medical practitioners who deal with traumatic brain injury, what percentage of people with traumatic brain injury have chronic pain? The textbooks will tell you it's sort of 80%. But if you talk to people who actually deal with people with TBI, they'll basically tell you it's 95% or all of them. So chronic pain itself is a neuroplastic process. So the brain is always trying to figure out how to do whatever it's doing more efficiently. And that includes relaying pain signals. So that's the basis of what chronic pain is. So it appears that this hemispheric balance can either happen because of an injury or it can happen because of neuroplasticity adapting to long-term chronic pain and making you more susceptible to field levels of pain. Now, there's a very big gap in the science between people observing this difference in two-channel EEGs and really understanding the underlying mechanism that drives that. Dr. Marco Loggia, he's done some brilliant work on looking at specific areas of neural inflammation. And that seems to correlate really well with levels of pain and things like fibromyalgia. The science is an early stage to link how the brain actually manifests, drives chronic pain compared to that two-channel EEG sort of area of hypothesis, but it's coming. And what I know for sure is that using that hemispheric balance theory as a basis, we've created a therapeutic that so far has worked really well in small studies on opioid use disorder and fibromyalgia. And now, obviously, the much larger studies coming down the pipeline, Mount Sinai, Duke, Cleveland Clinic. It's a new field that has a massive amount of potential.
Yeah, very much so. And I mean, you went to school in like Wharton, and then you apparently went to a Shenzhen-based accelerator to be able to make this. So very driven person, and you're just like, okay, I'm going to do this. Since then, you've tested 14 prototypes. The ones that you originally had weren't ideal, right? What kind of was the thing that worked in the end?
So really, the journey goes from me with two desktops, one running an EEG and one running a light and sound generating machine, through to laptops. And the problem was having to use EEG. That was the real issue, because with trying to deal with chronic pain or chronic anxiety or insomnia, you have to basically be able to look at a signal and adapt the stimulation to that signal. And if you're doing that with EEG, it can't be automated. And the central issue is electrodes. Have you come across Muse, the brain sensing headband? So Muse, in my testing so far, is the best commercially available dry electrode system available. It's a really simple headband that you put on when you're meditating. So I need to restart the company now so that with the infrastructure into which to put a sensor as soon as the sensors are good enough, that enabled me to stop everything else I was doing, going back to full-time work on the device. And very luckily for me, I got in front of the people of which the hardware component is called Hacks. They were the first institutional money into the company. They believed that, like I did, that I was on the right track. And they actually put the first institutional money into the company the day my son was born. So that was the day that really the rebirth of the company and the birth of my kid.
Wow.
That was the real start of the company.
Wow. That's amazing. That's really cool. So how has it been since then?
It's been quite a journey. I mean, we started off aiming to focus on being a sleep company. And I learned the hard way that VCs, generally speaking, hate consumer health. They reserve their deepest vitriol for consumer sleep. And the reason why is because within sleep, you can make any claims you want to make, and the FDA will not bat an eyelid. You can say you improve sleep. You've got the My Pillow guy on TV who holds his pillow up and goes, My Pillow helps you sleep better. And you don't have to have clinical data. So VCs don't like the space. They don't like helping startups in the space because they're making a bet on your ability to market. And over time, we morphed into, where can we help people the most? And that started us down the road of looking at very, very severe types of pain with neuropathic pain and then fibromyalgia. That led to the first 3 clinical trials. One was a 75-person study that we had help from Stanford and Special Operations Command via Softworks and the East Bay Chronic Pain Group. And those 3 groups gave me volunteers for that first 75-person study who had basically groups of no pain, medium pain, and very long-term severe pain. And that enabled us to look at how the device was working in each case. It showed us that the worst pain and anxiety and suffering someone was in, the greater the degree the device worked. It also gave us a shortcut to producing statistically significant results. In that, people with chronic pain tend to have a nocebo effect with sham or placebo devices. So whereas you pop a pill, most people will get on average 30% less symptoms or whatever they have. There's a rough ballpark. It varies hugely between drugs and conditions, but within mild pain to sometimes moderate pain, you'll see that figure. With severe pain, the nocebo effect basically means that you use a sham device and you get temporarily more pain. And that's because people get upset that something they thought was going to work and thought was going to be helpful wasn't. And that makes clinical trials easier because it means that you can then have a much smaller sample size and still hit statistical significance. We hit all of our secondary endpoints and our primary endpoints with statistical significance on each cohort of 10 and so on the combined 20. Turns out that that isn't enough for the FDA. The neuroscience group within the devices within the FDA have a tendency to want a 120-person study regardless of your hitting statistical significance. So now we are repeating some of that early clinical findings in the larger studies. And that's where we are today. The Mount Sinai study on neuropathic pain has started and appears to be going well, although we obviously can't see the data directly. We just know that some people have been helped quite dramatically. Obviously, this could have been helped by the sham. We think it's unlikely, but we cross our fingers and hope that the data looks as good as it's appearing. And then the study on fibromyalgia will be the next one.
Wow. Yeah, that's pretty incredible stuff. That's a hell of a journey. I mean, that's the entrepreneur's journey is like a roller coaster, and one day can be maddeningly amazing and horrible at the same time. But anyways, you have an interesting way to sell this. This is a consumer product, but you are doing monthly subscriptions. What is the logic behind this?
Well, two things. The first thing is that essentially we're a medical device going after reimbursement, but that takes a long time. So we've launched under a 513G confirmation from the FDA as a wellness device so that we can get early data and so that we can help people in a wide variety of things that they want help with. We just can't mention words like pain and anxiety within that marketing because we haven't yet got clearance on those. So we're launched as this consumer device in order to get out there and help people and to gather some early data, and whilst we're in the process of going through the FDA. Now, the costs of the research and cost of building each individual device mean that they end up expensive. And if you think of the average American family can't withstand a $500 shock to their system each month, having a device that costs a substantial amount of money puts it out of the reach of most people. Whereas if you spread that over time and you make that a payment that people can do monthly as part of a subscription, that then allows you to reach more people. The other factor is that we are providing long-term ongoing services. When they use the device, they are also, all that data is being fed through an app, which in due course will go back up to physician portals or when they want to share that data, where the current iteration is coming back onto their device. So they're going to be able to get feedback on how well the device is working for them and how different types of use improves their experience and improves their health.
Wow. Yeah, definitely. I think that's the better way to do it. I mean, you can get a sticker shock, especially if they're covering. If it is reimbursed, then that's a different story. But this is a much gentler way. I mean, that's why payment plans are so popular. That's why mortgages are so popular. That's nobody buys a house, boom, with cash. They'd rather go for the monthly payments.
Yeah, for sure. And also it means that people who do have severe issues get to try a device because we have a 1 month period where someone can return it for a full refund. So it basically means that, people who've tried multiple different things to help them with pain or anxiety or whatever can actually try a device at no financial risk. And that's very hard to do if you're charging people up front as well.
Yeah, I think so too. Well, Richard Hanbury, this has been excellent. Is there anything that we didn't cover that you wanted to mention?
I don't think so. It's been great talking to you. Obviously, I'd like to just say to people, if you'd like to know more, please go to the website. It's www.sana.io. And please watch our clinical trials in due course for spreading that to other indications.
Excellent. Thank you so much.
Thank you too. Cheers.
Hope you enjoyed the show and were able to learn something new, bringing together different fields in novel ways. Until next time on the Neural Implant Podcast.